And now introduce the symposium of MSD to be introduced by our chairman, Professor Amr Al-Husseini, about HPV disease and prevention. Professor Amr Al-Husseini and Symposium of MSD. Thank you.
Mr. President, thank you very much for inviting me to give this presentation. I would like to thank my dear friend, Professor Hatem Al-Gamal, the President of the ASOGIC 27, for this outstanding, unprecedented organization and scientific content that's awarded 64 CME hours, which never happened before. My name is Amr Husseini. I work as the director of the OBGYN department in Ain Shams University, and I was the director of the early cancer detection unit in Ain Shams University. For those who don't know about our early cancer detection unit, it was founded by our great professor Muhammad Bayoumi Sammour 40 years ago, and the main target of this unit was the early cancer detection of cervical malignancy. This unit has both gynecologists interested in gynecological malignancy and gynae pathologists, and we have an immense number of cases computerized and tabulated in our unit. We are now approaching 600,000 gynae pathology units. This is our king for the current time, Muhammad Salah. He is an example of perseverance, persistence, and genius of the Egyptian people. If we talk about cancer, we have to say that the vast majority of cancer occur by chance. We don't know at least the cause. So we would be very lucky if we are dealing with a malignancy with a known cause. Among these is the cervical cancer. Cervical cancer is attributable to infection, to human papillomavirus infection, and it's the second most common cancer caused by infection. If we have a look at the global burden of HPV-related cancer and disease in women, in females, it causes cervical cancer, vulvovaginal cancer, cervical dysplasia. In males, it causes penile cancer and anal cancer in both sexes, in addition to genital wart, recurrent respiratory papillomatosis, and oropharyngeal cancer. It's very important to notice that the second most common cause of oropharyngeal cancer is HPV infection. Cervical cancer burden is very high among women. It's the second most common cancer among women in the age between 15 to 24, and 99% of cervical cancer is linked to HPV infection. The prevalence of HPV in our country, according to the latest statistics coming from the Early Cancer Detection Unit, which is the only unit in this country which has data about the prevalence of HPV and cervical cancer. And I'll say again, the only unit in this country. The prevalence is about 14%. The human papillomavirus is a non-enveloped virus, and the HPV is presented as a genetic material, DNA, surrounded by a protein capsid. We all remember the natural history of HPV infection leading to cervical cancer, passing through CIN 1, 2, and 3, or in the newer classification, the Bethesda classification. Bethesda is a city in the United States, and it's classified to low-grade squamous intraepithelial lesion, and high-grade squamous intraepithelial lesion. The cervix is very friendly. It's unlike the ovarian cancer. It's easily seen, it's easily examined, it's easily brushed, so it's easily smeared, and this is a very simple test, and it's a shame if we don't do it, because it's easily accessible. In comparison to the ovary, which is very difficult to examine, very difficult to assess, and usually gives no symptom till the disease has been quite advanced into the pelvis and abdomen. And we need very few and very cheap instruments to do cervical cancer screening. We need a brush and a setup that has the facility to see the cervix if there is an abnormal smear. Traditionally, we used to have a binocular colposcope, which gives you a brilliant image. But unfortunately, the vast majority of our doctors do not document the basic data of the patients or what they found during the examination. So now we are moving to a digital colposcopy, because the software of the colposcope will not let you do the examination unless you enter the patient data. So you have to enter the patient data, you have to enter the examination results, and some new versions of the digital colposcopy with updated software have an artificial intelligence that will help you to diagnose the abnormality present in the cervix. So as you can see here, you can have a user-friendly report that tells everything about the patient, but most importantly, these data are stored so you have a database for the patient. If we review quickly some photos of the cervix, this is how the normal cervix looks like. This is an acetowhite area when we add vinegar, acetic acid 5%. And here is an iodine negative area if we add a Logel's iodine. So it's very simple, very clear to everybody. And this is a high-grade squamous intraepithelial lesion. These are abnormal blood vessels, and this is invasive carcinoma of the cervix. There is a problem in the cervical cancer that it has a very costly burden, because the disease is usually diagnosed in midlife, at the prime of human ability. Unlike other cancers that are diagnosed later on in life. For instance, lung cancer is diagnosed at the age of 71, breast cancer usually at the age of 63, and so on. So cervical cancer happens at the prime of human. And these are the average age of diagnosis in cervical cancer, 50 years, but about 40% of these cases are diagnosed before the age of 45. There have been milestones in the diagnosis and management of cervical cancer, which we turned in this country a blind eye about it. Till today, we don't have a cervical screening program. They started the cervical cancer screening program in the 60s in the UK. Until today, in 2024, we don't have a cervical screening program, a national cervical screening program. As we don't have a national screening program for breast cancer or for prostate cancer. We have initiatives, but we don't have a national screening program. The idea of HPV vaccination is the concept of virus-like particles. We use the virus-like particles to stimulate the immune system so the vaccinated person becomes immune against the types of virus he has been vaccinated against. We have to remember that there are over 150 types of HPV. And currently, there are 3 types of vaccine: the bivalent vaccine, the quadrivalent vaccine, and these 2 are present in Egypt, and the nanovalent vaccine, which is the only type present in the USA, the only type present in most of the Western countries, the only type present in United Arab Emirates. So this is the most effective vaccine as it covers more oncogenic types. And the efficacy of the vaccine is ranging between 98%, especially to 100%, especially when given early in life. And when I say early in life, I mean before the age of 17. And this graph will show you the difference between the incidence of cervical cancer between the non-vaccinated, those who are vaccinated between 17 to 30 years old, and those who are vaccinated before 17 years old. The WHO Director General calls for countries to take actions to help end the suffering caused by cervical cancer. And they released a statement saying that no woman should die from a deadly disease that's both preventable and curable. We have a disease that could be prevented and could be cured completely if diagnosed early. And the WHO global strategy for elimination of cervical cancer by 2030 is that 90% of women should be vaccinated, 70% of women should be screened, and 90% diagnosed with cervical disease should be treated. Where do we stand in this WHO initiative? We stand nowhere. And what's making me very upset about our position is that among us, among the gynecologists, we have denial that we have a problem. We have people here in this country saying that it's a sexually transmitted disease. We are a religious country. We don't have HPV. While the science tells you that 80% of sexually active humans will have HPV at some stage of their life. 80%. You can't debate with science. If we look at the global HPV vaccination introduction, these countries with the blue color have a national screening program. And these have a substantial effort to introduce the national screening program, a vaccination program. And these countries have done a demo complete. But we have no color. We have done nothing. Let's have a look about our region. Libya, which is in a civil war since 2011, have introduced the compulsory vaccination 2013. United Arab Emirates, Abu Dhabi, Saudi Arabia, Morocco, even some countries now have a gender-neutral vaccination. They are not only vaccinating females, they are also vaccinating males. So the question here, which is the main thing about this presentation, with a country with limited resources and limited education, what's best for us? Shall we do screening for cervical cancer, or shall we do vaccination of the population? If we look at the screening, we need to screen 70% at least of the population. This needs to be repeated every 3 to 5 years, and it needs expertise. And here I have to stop, because if you send a pap smear from a patient with marked HPV to one of the big labs here, I can assure you that 90% of the time you will have the result saying it's a chronic cervicitis. There are very few people in this country, very few gynae pathologists who can read a pap smear properly. And the pap smear, at best, the accuracy does not exceed 70%. And if you need to do a proper screening, you need to do a co-testing between HPV PCR vaccination plus liquid-based cytology. The second thing, it's ideal to do co-testing, as I told you. While if you do vaccination, it's less expensive, especially if done between 9 to 13 years, and it doesn't need any expertise. Just any nurse can give the vaccine. So cervical cancer screening or vaccination, I think you can tell what's the correct answer. But if we vaccinate everybody, can we stop completely or cancel screening? The answer is no. If we vaccinate our children at the age of 13, we have to screen them at least once by the age of 30, and this will be less expensive. And if we start today to vaccinate, we can start screening after 17 years from now. And this means that we will be better off. So let's keep it simple regarding the vaccine. It is effective, it is safe, and it is recommended. Thank you very much.
Thank you, Professor Dr. Amr Al-Husseini, for this excellent presentation and informative presentation about the human papilloma virus, which is the most common viral sexually transmitted disease. And you raised the problem if it is only sexually transmitted or could be transmitted by non-sexual route. The next speaker will be Professor Dr. Hatem Al-Gamal on the symposium about the thoughts on the maternal micronutrients, supplementation, and fetal programming.
Thank you, Mr. Chairman. We will talk about important subject in our practice, which is the use of the micronutrient supplementation during pregnancy. Of course, pregnancy is a period of intense fetal growth and development, as well as maternal physiological changes. Undernutrition and overnutrition can be associated with adverse pregnancy outcomes. These effects can be observed in short term, but also in long term. The idea of long-term complications comes from the theory of Barker, David Barker, who put the theory of the fetal programming, the fetal origin of adult diseases. This has come when the baby in utero, and the paper was published in 1976, and weight in infancy and death from ischemic heart disease in the future. This comes from the Dutch famine, which occurs in المجاعة اللي حصلت في هولندا during the Second World War. Dutch famine, or the hunger winter, November 1944. Food ratios they take only 400 to 800 calories per day, and about 4.5 million people affected. And coming in the New England Journal in 1976, obesity in young men after famine exposure in utero and early infancy. And this here you can find the difference, the Dutch famine, obesity in prevalence in young women, in young men. Here we find those infants who exposed to the Dutch famine late in pregnancy, and here you find that those exposed to the famine during the first 2 trimesters of pregnancy, of course, the number and the obesity is more when the woman is exposed to any deficiencies of the micronutrients during the first and second trimester of pregnancy. Any stimulus, this is the statement of Barker, any stimulus or insult at critical period of embryonic and the fetal development can result in developmental adaptation that produce permanent structural, physiological, and metabolic changes, thereby predisposing an individual to cardiovascular, metabolic, and endocrine disease in the adult life. يعني الاسكيميك هارت ديزيز والاوبيزيتي والمشاكل اللي احنا بنشوفها بدايتها من الفيرست والسكند trimester of pregnancy due to deficiency of some micronutrients. The body's memory of undernutrition during the early stage development translates into pathology that determines the future diseases. The fetus adapts to maternal malnutrition through changes in the production of the fetal and the placental hormones that regulate metabolism, redistribute the blood flow, and control the growth. ومن هنا هتبدأ تظهر الانسولين resistance في المرحلة دي. The immediate metabolic response of the fetus to malnutrition is to consume its substrate to produce energy through metabolism. Undernourishment of the fetus causes metabolic dependence on glucose to both decrease and increase the oxidation of other substrates such as amino acids and lactic acid. So the metabolic process of storing glucose continues into adulthood, and that insulin resistance is the result. Barker hypothesized that the fetal environment causes epigenetic modification that impact gene expression and thereby influence development of the disease in the children and adults. So it is not a genetic problem, it is an epigenetic. This is due to the environment. البيبي ده اللي نزل بالمنظر ده هو اللي بعد كده البيبي اللي طول النهار ياكل جانك فودز من ماكدونالدز وكنتاكي وحاجات زي كده. Effect of programming involves structural changes, important organs, altered important cells, imbalance in distribution of different cells, and also to abnormal insulin resistance resulting in type 2 diabetes, reduced vascularity causing hypertension, and reduced nephron number also produces cardiovascular disease. WHO in 2016, this is the statement of WHO 2016, supplementation is not recommended for all nourished pregnant women in developed countries. There is a good evidence of benefit of iron and the folic acid supplementation. Populations with high prevalence of nutritional deficiencies might consider the benefits of multiple supplements on maternal health. This was the recommendation of WHO 2016, iron and the folic acid, and in the developed countries, and they may advise to give micronutrients in the developing countries. But in 2020, this is the recommendation, the final antenatal multiple micronutrient supplementation that include iron and the folic acid are recommended in the context of rigorous research. يبقى احنا خلاص حكايه ايرون وفوليك اسيد دي انتهت. احنا بنتكلم على multiple micronutrients, and this recommendation both in developed and developing countries. The recommendation is based on evidence derived from the study of the multiple micronutrient supplementations. About 15 micronutrients are supplied in the study of the United Nations International Multiple Micronutrients Application, which contains 15 micronutrients, including 30 milligram or 30 milligram of iron and 0.4 milligram folic acid. And this study contains 30 milligram iron, 40 acid, 10 trials conducted in different countries in Bangladesh, Burkina Faso, China, Guinea-Bissau, and Indonesia, Nepal, Niger, Pakistan, and contributed data to this comparison. And the result, the evidence on maternal outcomes suggested little difference between use of the multiple micronutrients and iron and folic acid alone. But the fetal outcome is completely different. This is the short-term fetal outcome. The evidence on the effects versus iron and folic acid supplementation is showing a reduction in the low birth weight, and additionally suggested a reduction in the small for gestational age and the reduction in the neonatal mortality with the supplementation of the multiple micronutrients. These are the short-term results. As long as the longer-term results, also there is a lot of benefits regarding the use of the multiple micronutrients. Starting with these multiple micronutrients, the iron. What is the iron? Iron is a mineral that is found naturally in many foods as a component of myoglobin and other proteins, important of course of the hemoglobin. Iron supports muscle metabolism, but iron is also important for physical growth, neurological development, cellular function, and synthesis of some hormones. Iron is not only present in the green foods, as we all know. Iron is mainly, we have the heme iron and the non-heme iron. The most important iron is the heme iron, which is present in the meat, poultry, and in fish. And this type of iron is not affected by absorption of, for example, taking a cola, taking tea after the lunch, or taking tea after the dinner. It will not affect the absorption. But the non-heme iron, which is present mainly in the green vegetables, will be affected by the other types, its absorption is affected by the presence of the dairy products like the coffee, tea, and Coca-Cola. So the most important is the heme iron. There is a strong evidence that iron supplementation in non-anemic pregnant women, improves the maternal or the child clinical outcomes. Iron deficiency, and we must differentiate between the iron deficiency and the iron deficiency anemia. Iron deficiency anemia is a late stage of iron deficiency that inhibit the process of the erythropoiesis. So it is not easy in the first visit or in the visit antenatal visit. Please ask for the ferritin measurement, not only the anemia, not only the hemoglobin to be measured. So iron deficiency is the most common deficiency state in the world, affecting more than 2 billion people globally. Although it is practically prevalent in least developed countries, it remains a significant problem again in the developed countries. And these are some symptoms from the iron deficiency, like the headache, pale skin, dizziness, leg cramps, heart palpitation, irregular heartbeat, slow blood flow, and the brittle nails. And here is the stages of the iron deficiency, as I said. The iron deficiency stores, and then the iron deficiency, and finally the iron deficiency anemia, which is the late stage of the iron deficiency, as I said. And these are the complications of the iron deficiency and recommendations of iron deficiency according to the WHO is about 27 milligram per day. And please, when the WHO put the daily requirements, they put according to the iron salts, but we have different methods of manipulations of the iron helping the absorption and the bioavailability. So this number of 27, so when you take a pamphlet and you find that the iron is less than 27, please show the method of the cheliation, bisglycination, the sucrosomal iron, and different methods for absorption of the iron. Folic acid is, of course, all of know the importance of the folic acid, but the most important is what is the folic acid in special conditions. We all know that the recommendations about from 0.4 to 0.8 milligram of the folic acid 3 months before the pregnancy. But in a special situation, the optimal preconceptional first trimester folic acid for women in other risk groups is unclear. We suggest the following: family history of the neural tube defect, 1 milligram of folic acid. Women on valproic acid and carbamazine, 4 milligram folic acid. Women taking medication that other than anti-epileptic that have been associated with reduction in the available folic acid, give 1 milligram folic acid. Women with medical conditions associated with reduced red cell folate levels, 1 milligram. And women with pre-gestational diabetes, please give him 1 milligram of folic acid. Calcium is another important factor, and calcium always working together with the vitamin D and with the magnesium. So calcium, magnesium, and the vitamin D working together. So if you have a calcium, you should ask about the magnesium, and you should ask about the vitamin D in the capsule of calcium. Calcium is the most abundant mineral in the human body. Adult weight, 70 kilogram, contain about 1.2 kilogram of calcium, essential in various body functions. That's why calcium is present in most of our food. And these are the list of the foods in that contain the calcium. You didn't find the eggs in this. So egg is not a good source of calcium unless you take the egg with her cover. اللي هتاكل البيضه بقشرتها، لكن البيض ما هواش سورس كبير قوي للكالسيوم زي ما كل الناس متوقعين. كل بيض لا، الكالسيوم مينلي موجود في الملك، في اليوجورت، في الكيل، في التشيز، في السردينز، في البروكلي، في الاوكرا، في الالموندز، في الجرجير. الحاجات اللي دي مليانه كالسيوم. البيض ما هواش سورس كامل للكالسيوم. مش معنى كده مديش بيض، بس هو ما هواش سورس اساسي للكالسيوم في جسمنا. طبعا الفانكشنز اوف ذا كالسيوم كتير قوي، لكن احنا بنقول the total relatively percentage of total maternal body calcium is easily mobilized from the maternal stores. If necessary, intestinal absorption and renal retention of calcium increases progressively through digestion. يعني البيبي هياخد كالسيوم فهي سواء خدت كالسيوم ما خدتش كالسيوم هياخد كالسيوم even from her bone. So calcium supplementation is a must during pregnancy, and the recommended daily allowance for elemental calcium is 1,000 milligram per day for pregnant and lactating women. For women with low baseline dietary calcium and high dose of calcium supplementation may reduce the risk of the hypertensive disorders of pregnancy, especially the preeclampsia, is reduced with the use of calcium, but in more higher doses. Again, the magnesium, the most common cause of the cramps that occurs to the female, is important to be supplemented, and the ratio between the calcium and magnesium in the capsule is about 3:1. Vitamin D, and we are in the era of the vitamin D deficiency. We don't know why, but the vitamin D is deficient in a lot of patients, so we must supplement the vitamin D. Other indications for the vitamin D, also important for source for vitamin D, is the sun. Sun is responsible for conversion of the vitamin D to the active form of the vitamin D. So eating alone is not enough. We must expose our children, or the pregnant woman must be exposed to the sun. For routine supplementation, we agree by the Institute of Medicine report suggesting the daily allowance of international units of vitamin D for all reproductive women, about 600 milligram. Also, we have the zinc, and also we have the selenium. Taking zinc during pregnancy helps slightly to reduce the preterm labor. Selenium is considered the armor of the body. It is important during pregnancy as a defense mechanism. Vitamin A, again, is important. It is not forbidden to give vitamin A during the pregnancy. This is very important, but not a lot of vitamin B. But we need the vitamin A, but not excessive amount of the vitamin A. Also, other vitamins via vitamin E and the vitamin C are important in this. We have our product, the Vitatron. It is about 31 nutrients, including all the micronutrients that the lady needs during pregnancy, and is also gentle for the stomach. It prevents the placental dysfunction and essential for the embryonic and the fetal growth development, promotes immune system, improves the pregnancy and the lactating outcome, corrects the nutritional deficiencies, reduces the general fatigue and weakness, keeps calcium homeostasis, bone metabolism, and cellular proliferation. Thank you very much. By this we end our session, and we are in break for half an hour, and then we will do
Thank you,
3
Professor
parallel
Hatmi.
sessions together. Thank you very much.